Okay, good evening. I think the time has come to go to our next presentations. And right now we're going from learning about educational examples to getting a community holistic approach and getting some global experience by knowing more information about the Cuban experience. So we have two speakers actually with us this afternoon for the next 45 minutes. Lillian Holloway, Dr. Lillian Holloway, actually she's with us actually by phone. So I hope she's hearing or listening to this conversation. Are you there, Lillian?
I'm here, thank you.
Oh, great, thank you. But before Lillian, actually, we gave her an opportunity, I would like to introduce Dr. Pierre LaRamee. And Dr. Pierre is an executive director for Medical Educational Corporation with Cuba, MEDICC, and he's from Oakland, California. He's going to give us a wonderful presentation, I believe. So please, Dr. LaRamee, welcome.
Thank you very much. Full disclosure, I'm not a medical doctor. I'm one of those social scientists that we've been talking about all afternoon. Joe's going to be a tough act to follow, so I think I'll just hop across the Florida Straits to Havana and look at the view from there. I know that many of my Cuban colleagues would love to meet him and to hear about his program. However, I think they would find that they have a lot in common. So let's jump right in. This is a summary of Cuba's health outcomes, and I want to tell you a little bit about give you a bit of a health profile of Cuba, so that you'll be in a position to understand what I'm going to say about medical education and the Cuban healthcare system and consequently medical education. You have universal literacy, potable water, lowest rate of infant mortality in the hemisphere, including lower than the United States, under 5 mortality at 5.8. Maternal mortality higher than they would like it to be, and are still working on bringing it down. It's at 33.4. Life expectancy 79 years, more or less the same as the U.S. The main causes of death: cancer and heart disease. In other words, Cubans, while living in a very poor country, are dying from the same diseases as people who live in rich countries. Efficiency and outcomes comparisons. If you look at the numbers highlighted in red, which are the most critically important ones in this chart, you have Canada, Cuba, and the U.S. You see expenditures on health as a percentage of GDP per capita, a little bit higher than Canada at 11.3 versus 10.8, quite a bit lower than the United States at 17.2. That may actually even be a little higher now. Canada, the health care cost per capita, $5,630. These data are 2013. U.S. $8,608, Cuba $606 per capita. So in a sense, similar outcomes looked at globally are being achieved at a much lower cost per capita. Let me go back a little bit here. If we look at virtually every critical area of public health and medicine facing poor countries, Cuba has achieved remarkable successes. And just to list some of them, they've created a high-quality primary care network, a very effective public health system, educating a skilled workforce. They've sustained a local biomedical research infrastructure. They've controlled infectious diseases. And they've achieved a significant decline in non-communicable diseases, and doing all of this while often meeting the emergency health needs of less developed countries, including their recent delegation to West Africa to help control the Ebola outbreak. This is the structure of the Cuban healthcare system. How did we get here, and how did it allow the Cubans to Cuba to achieve these remarkable results? In 1959, the Cuban Revolution inherited a health sector with 2/3 of its 6,000 physicians living in Havana, living in the capital city. There was virtually no primary care for the poor or for the rural population. By the 1970s, they had a system of regional polyclinics and hospitals, which was complemented in the 1980s by a reorientation of the entire system towards primary care and the education of large numbers of family doctors. An emphasis on social determinants of health was established, taking into account biosocial, cultural, and economic factors, and this was incorporated into residency training as polyclinics became teaching sites and primary health care became the linchpin of the emerging national health system. By the 1990s, the strategic goal was reached whereby a team of a family physician and a nurse lived in every neighborhood and provided care for up to 120 to 160 families. This is the existing system as diagrammed in this slide. Now, as you can see, it's up to about, it says about 1,200 individuals. In some cases, it's up to about 1,500 individuals as health data. As population health overall has continued to improve, they found that they can increase the number of patients per family nurse office. Looking at this diagram, you see you have the family nurse office at the neighborhood level. You have about 11,500 of these, somewhere between 11 and 12,000. You have basic work teams, and these report to the polyclinics. In fact, they're based in the polyclinics. What do these basic work teams do? They oversee their network, their local network of family doctors. So the polyclinics are the secondary level in the system. The work team will have a nurse, an OB/GYN, an internist, usually a social worker, and they oversee the performance of the doctor-nurse offices. So there are about 450 of these polyclinics, and they serve 20,000 to 40,000 people in their catchment areas. Then you have 152 hospitals and 13 higher level research institutes. So, MEDICC. I've talked a little bit about Cuba, and I'll talk a little bit about MEDICC. MEDICC was founded in 1997. It's called Medical Education Cooperation with Cuba. We're a nonprofit organization working to enhance cooperation among the U.S., Cuban, and global health communities aimed at better health outcomes and equity. Our vision is health for all is possible. And our mission is to promote cooperation among the U.S., Cuban, and global health communities to improve health outcomes and equity, offering the Cuban experience to inform global debate, policies, and practice. We do this through this work through a number of programs. Basically, we're building these bridges between the U.S. and Cuban medical and public health communities. We do this through people-to-people exchanges. In other words, we bring delegations of public health personnel and medical personnel to Cuba. We also publish a medical journal called MEDICC Review. You can find it online. That basically presents, it's the only peer-reviewed medical journal that presents the research of the Cuban medical and research community in English to make it available to a wider audience. And I'll tell you a little bit more about two other programs. One is Community Partnerships for Health Equity, CPHE. This brings together Cuban health professionals and leaders from U.S. medically underserved communities to work on priority local health problems in those communities. In other words, we have delegations of just doctors and public health people, but we also have delegations where we bring local community leaders, activists, folks who are interested in resolving some of the health problems in their communities. We send them in groups combined with public health and medical professionals, usually academicians, and they get to see for themselves what the Cuban model looks like, and they come back with examples that they themselves discover they would like to implement, with which they have some commonality. We have these now in South LA, Oakland, Albuquerque, the South Bronx, Akron, Ohio, and Milwaukee. We're in the process of developing one in the Navajo Nation as well. CPHE 2.0, Sustainable and National. This is through, with funding from the Robert Wood Johnson Foundation. We've taken the first 4 CPHEs and given them seed grants, and we're providing technical assistance and capacity building to make them more sustainable. How does this relate to medical education? Basically, participating in a CPHE for us is a means to providing mid-career health professionals with training in strategies to address social determinants through their participation in a community-based collaborative that uses the Cuban model as a source of inspiration and learning. Another one of our programs, our education program, provides support for USALAM medical students and graduates. You're about to hear from one of those graduates, Dr. Lillian Holloway, after I'm done with my short presentation. These are students from the US who receive a full scholarship to study at ELAM, at the Latin American Medical School in Havana. The programs that we provide for them are scholarships to defray US board exam costs. We've given 123 of those since 2007. We give step prep workshops in Cuba, and we see steadily increasing exam scores as a result of these efforts. Then we have community connections, clinical opportunities in community clinics and public hospitals throughout the US. We've had 137 placements since 2009, and this has included didactic lecture series as well as simulated patient experiences. We have pathways to residency. We identify and develop physician mentors to assist with residency preparedness, and this includes financial support for professional conference attendance on the part of ELAM graduates. And finally, residency outreach. Outreach to primary care programs with similar social missions. And we regularly attend professional conferences to work on developing these relationships and identifying potential residency sites for ELAM graduates. So US ELAM residents, 62% work in health professional shortage areas or medically underserved areas, and those not working in HPSA or MUA are working in the public sector with underserved communities. So USALAM residents in MEDICC's programs, 91% participated in our programs versus 9% who did not. So we're clearly, I think we've had the ability to capture the interest and attention and participation of ELAM graduates, and to be able to help them along this road, this pathway to residency. The specialty of residents, mostly family medicine, two-thirds, internal medicine, 22%, emergency medicine, 3%, and pediatrics, 9%, pretty much what you would expect to see in Cuba. In the Cuban system, everyone does a residency in family medicine. That's the specialty that everyone begins with, and then they can further specialize in other areas of medicine. So I'm going to stop now. I'll take questions at the end of the presentation. I'd like now to turn it over to Dr. Lillian Holloway, who'll be on the phone. We couldn't get, she has a slide presentation, but we couldn't get her video on. Instead, she'll just be talking to us by phone. Lillian, welcome.